morning, everyone. I hope you're all doing well today. I'd like to welcome you all back for the final day of our virtual 2021 Opiate Conference. I'm Sherrá Watkins, and I'm the CEO of the Ohio Association of County Behavioral Health Authorities. As we get started today, I want to again thank our conference partners, the Ohio Department of Mental Health and Addiction Services and Director Chris, and the Ohio Department of Rehabilitation and Corrections and Director Chambers Smith. They've been longtime sponsors, and we really count on their sponsorship, and we like to work so much in partnership with them, so we really want to thank them. I also want to thank all of our other sponsors, BioCar RX, HICMA, Interact for Health, Indivior, CareSource, the Ohio Department of Health, the Ohio Suicide Prevention Foundation, and the Cardinal Health Foundation. And again, many of our sponsors have been long-term sponsors, and we really love working with them. And they really have allowed us to be able to continue our opiate conferences. Remember, you can visit the conference sponsors and our exhibitors in the OACBHA app, and it's at the exhibitor tab. And I really encourage you to go visit. They've got some really good and exciting information and some things that can really help you out in your day-to-day work. So please give them a visit. At the end of the day, just as a reminder, you will receive an email from Michaela Radish with a survey link. This survey is our daily evaluation form, and we're asking you to complete the evaluation at the end of the day. The evaluation is required for any of those of you who need continuing education credits, and we will be taking kind of attendance through Zoom, so we'll be knowing who's there, and you need to stay for the entire session in order to get those education credits. Also, please make sure that you're signed in from your own device with your own name, so that we can assure that you get the credits that you're looking for from CEUs. I also, again, I want to thank Michaela Radish for everything she's done to pull this conference together. I know she's been the contact for all of you, but I also want to thank all of my other staff for everything they've done to really make this a successful conference. You know, this is our first time doing it virtually, and so far we've had great response, we've had great feedback, and we've really had great speakers for all of our general sessions and for our keynotes, and I'm really looking forward to today's keynote as well. So again, thank you for coming back. If you have any questions or if you need any help, please, throughout the day, you can connect with anyone on our team. You can go through the OACBHA app or you can use email. So we're going to go ahead and get started on today's activities. As you all know, we really believe that we have to shine a light on recovery. That is what we're all here about. And shining a light on recovery is so important to us. And so this morning, we're going to start with a recovery story again, and I'm thrilled. We have Kyle is going to be speaking with us this morning. So with that, Kyle, I'm going to turn it over to you. Thank you. And thank you for being here.
Thank you. And good morning to everyone. And it's both an honor and a pleasure to be here to share my story. What I'm about to tell you is this is a true story, and it's not embellished or, or imagined or anything, but I'll share it all. My name is Kyle Overmeyer. I am the former sheriff of Sandusky County, and I was also an inmate, and now I am a community outreach for Seacrest Recovery Center in Columbus, Ohio. So my story, I'll make it short and sweet, and it begins with, I grew up in a great family. My father was in law enforcement for 38 years, captain of Sandusky County Sheriff's Office. I went to a Catholic school, brought up, went off to college for a while. My mother, she was a good mother as well. Neither of them were addicts. From Catholic school, I went on to the University of Toledo for 2 years. Unfortunately, I didn't know what I wanted to do. I dropped out, worked in a couple factories, and then decided to follow my father's footsteps. From there, I went back to college, the police academy. I was hired in 1996 as a corrections officer at Sandusky County Sheriff's Office in Fremont, Ohio. And I quickly moved up, and during that time, I went back and got my associate's degree at Terra State Community College in criminal justice, and I have a bachelor's in business administration from Tiffin University. I really put my heart and soul into law enforcement. I went from the road patrol to a sergeant, detective, captain, and I even worked briefly undercover for DEA for 3 years. And unfortunately, our sheriff passed away. and they had an emergency election, and I ran, and at the young and tender age of 34, I was elected sheriff in 2008. At that time, I was the youngest sheriff in the state, and I'm still the youngest sheriff in the Sandusky County history. That time, there was a lot of things going on at, of course, being the sheriff and running a agency that big, and being a 34-year-old guy, married. I had 2 children, and I was then diagnosed with arthritis. So, of course, the doctors then prescribed me with Vicodin. I was taking 105 Vicodin a month during that time when I was sheriff. And between, unfortunately, a failed marriage and the problems going on at work and that, my mental pain overcame my physical, so I became addicted to opiates. Things evolved where I would run out of my medication, and I began doctor shopping. I went even as so far as stealing old pills out of the take back. Well, eventually, by the grace of God, I was red flagged at the pharmacy, and the pharmacist pulled me aside, and she said, "Look, Kyle, you're getting from too many doctors, you're done." So in 2015, I eventually, on February 3rd of 2015, I eventually went cold turkey, and I got clean. I got clean and sober, and I got really sick. I did it the hard way, didn't ask for anyone's help. No one knew, but I thought I was in the free and clear, but I was totally wrong. I was up for re-election then in 2016, and a bomb dropped. I was hit with a 43 count indictment, and I was looking at 15 years in prison. I was still in denial. I would not tell anyone that I was an addict and I was recovering. I continued on to run for sheriff because of denial and shame and my ego. And then as time went on, when I went through my court proceedings, they revoked my bond, and I ended up surrendering. And I eventually came clean, pled to 12 counts, and I eventually not only stayed clean, but opened up. I went and served 4 years in prison. From those years of 4 in prison, so now I'm sober 6 years, and I did 1 year of parole. And coming out of prison, I was, how could I get a job, falling from being the sheriff to what am I going to do? And eventually I got out of prison, got a job. My first job was actually frying chicken at a local restaurant up in Fremont. And as time went on, I became very active in the recovery field. I got my first job as a behavioral tech at Recovery Institute of Ohio in Sandusky. Then I evolved into running groups, and then now I do community outreach here in Seacrest Recovery Center and help people and go out and share my story like I am today. And I guess why I'm really sharing my story today is because there's three things you need to really keep in mind. Is that the discrimination. This disease does not discriminate. Who would ever thought that the sheriff of Sandusky County would become an addict, and go do prison time and stay clean? But it happens. It doesn't discriminate. And with both mental illness and addiction, we hold that that stigma. And it's just not a certain type of person. And people need to lose that stigma and open their mind and their heart. I mean, it can affect anybody. Nobody is bulletproof from this disease. And also recovery. And like I like to share it with all the clients that I work with and all the other people, at Seacrest Recovery, and I use social media to share my story. But if I can do it, anybody can do it. I went from losing it all to I feel like I gained it all now. So I just wanted to share a little bits and pieces. It's very brief. And I know there's a lot of time, but this is kind of a unique story. I've been on both sides and I'm still clean, and sobriety is a beautiful thing. And if there's anybody that has any questions, I'm always feel free to ask me or message me or reach out. Or if anybody ever wants me to share my story with somebody, I'd love to. I'd love to. It's a great thing. And as time goes on, me sharing the story is good for my recovery.
Well, good morning, Kyle. How are you this morning?
I'm doing great.
I'm so glad, Kyle. My name is Kay Spergel. I am the Executive Director of the Mental Health and Recovery Board of Licking and Knox counties, and also the current president of OACBHA. And Kyle, I have to say that your story just made my heart sing this morning. I got up this morning, I thought, my God, what a beautiful, beautiful morning, and came in, and I have to tell you, listening to your inspirational story and how beautifully and just how openly you have shared of yourself is such a gift to me, and I'm sure many other people on this morning's Zoom video conference. And I, again, just want to thank you so very, very much.
No, and I appreciate it. And, it's a little bit broken. There's only so much allotted time, but, if anybody ever wants me to come in and do a full-blown speech, I'd love to share it. I'd love to share my story. I'm now out, actually, I've only been out of prison a little over a year. I served 1 year parole, and thank goodness they let me go early. And so a lot of great things have happened in this year.
Well, wherever you are this morning, for people that are participating, if you could please join me in a round of applause and celebration for everything that Kyle has brought to us today. Thank you, thank you, thank you. And now it is my great honor to ask our team to queue up a video. Unfortunately, Governor DeWine's schedule did not allow him to attend in person today, but he was able to record a short video for us to share with you. Can we play the video?
Hello, I'm Ohio Governor Mike DeWine. Thank you so very much for the work that you're doing to help your fellow Ohioans. This past year has been tough as we've endured the COVID-19. With a traumatic event like the pandemic or a natural disaster, research shows that a surge is normal. Ohio has seen an increase in the number of people experiencing stress, anxiety, and depression. More people have turned to alcohol and other drugs to cope with the stress brought on by isolation, loss of work, loneliness. In this struggle, I see the strength and resiliency of so many Ohioans. With your help and support, I see hope for Ohioans who face substance use challenges. Together, we can make a positive impact. Together, we are stronger. Throughout the pandemic, the state has proactively worked to ensure that life-saving drug naloxone has remained widely available to our law enforcement and frontline workers, as well as the public through mail-order naloxone. House Bill 341 has allowed for expanded access by making it easier for many organizations to distribute naloxone. In Ohio, we have also made great efforts during the pandemic to ensure access to personalized care through telehealth expansions and flexible guidelines for medication-assisted treatment and take-home methadone. While we know these methods do not work for everyone, they have afforded many Ohioans the ability to stay in treatment and stay safe during the pandemic. Policymakers, insurers, treatment centers, physicians, and those in recovery have all had to navigate the unknowns during this once-in-a-100-years pandemic. The progress that has been made around access to treatment will have a lasting impact on Ohioans. I would also like to recognize the one-year anniversary of connecting Ohioans to care through the Ohio Care Line. In the past year, counselors have fielded more than 6,000 calls from people in all 88 Ohio counties. Most people who call are seeking information on mental health and substance use disorders. I know your work can be tough, heartbreaking, and at times draining. I hope you're taking care of yourselves and practicing regular self-care. We want you to remain strong so that you can help others in need. Thank you. Thank you so much for your dedication. You make a difference every single day in the lives of so many Ohioans. We are a stronger, better, healthier Ohio because of you.
We want to thank the governor for his very inspirational and affirming video message this morning. That certainly means a great deal to all of us here. It is now my pleasure to introduce our next speaker, Recovery Ohio Director Alisha Nelson. In one of his first acts, Governor DeWine named Alisha Nelson as the director of the newly formed Recovery Ohio office. This showed a true and lasting commitment from this administration to support the mental health and addiction community. Director Nelson has led the Recovery Ohio office and the Recovery Ohio Advisory Council throughout the last 3 years and very much helped to prioritize the needs of individuals and families impacted by mental health and addiction at the state level. We are so pleased she's able to join us for this session, and we look forward to her comments. Director Nelson, I turn it over to you. Welcome and good morning.
Good morning. Thank you, guys. Thank you, Kay, and good morning and hello to everyone. Thank you for allowing me some time on your agenda. I just have to start by saying thank you to Kyle. I know it's hard to do these things virtually, to hear the feedback, but I'm so honored to hear your story and so inspired by it. So thank you so much. And I just see the comments. I know that I'm not the only one on the call today that was really, inspired by and needed to hear just that hopeful message that you shared of recovery and just that recovery is beautiful. So kudos to you, sir. As Kay mentioned, my name's Alisha Nelson. I am glad to be here today to represent the Recovery Ohio team and all of the agencies, boards and commissions at the state level that are a part of the Recovery Ohio team. Really what Recovery Ohio is a part of the Governor Mike DeWine's office. And our mission is really to create a system to help make treatment available to Ohioans in need, support services for those in recovery and make sure that those services are available, offer direction for our state's prevention efforts, and really work with local law enforcement to provide the support they need to fight the supply of drugs that are coming into our state. And also the more, I think serving role of law enforcement of helping people get to treatment supports that we're seeing more and more law enforcement take part in. So really excited to represent all of the individuals behind what makes Recovery Ohio a success. If we can go to the next slide, you heard the governor mention that in the video, what we know historically is that research tells us that a surge is normal following a traumatic event. And I think all of us have can attest to how challenging this last year has been. Our country as a whole has undoubtedly seen an increase in the number of citizens experiencing stress, anxiety, depression, and individuals have turned to alcohol or other drugs, as the governor mentioned, to deal with that stress and that loneliness. And really, it's been a challenging year that I think we all can work through. What we know, and just some of the bad news, if you go to the next slide, is that this is proven true and that these impacts have had an impact on everyone across the country, and certainly here in Ohio. The Ohio Department of Health unintentional drug overdose numbers for 2020 are in front of you. Ohio is unfortunately looking at numbers higher than 2017, which at one point 2017 was our recorded highest year ever of overdose deaths. And I'm sad to say that 2020 is now our record high year of unintentional drug overdose deaths. This trend was not immune to the rest of the country. According to the CDC, over 81,000 individuals we lost 81,000 people. And that we talk about these numbers, and these are humans, these are people. I just have to make sure that we understand that at that point, I know all of you do. 81,000 people died from drug overdose deaths in the United States in the 12 months ending in May 2020, which was a 24% increase overall from the previous year's numbers. Going to the next slide, the good news, despite all of this, is that there's hope. And what we heard in Kyle's story today is that recovery is possible and recovery is beautiful. And from the start of the epidemic and the pandemic, the state has worked with you to make sure that the behavioral health care field has remained open and provided the tools and necessary supports for Ohioans. One example of that, if we take a look at our work, is that we have continued to support access to naloxone. And some of you may have seen this in the recent news. There are several plans in place to continue our increase of distribution of naloxone across the state. We know historically that May and June are our peak months in Ohio. We're right in the middle of May right now. I want to make sure that all of you have the naloxone that you need to pass out to the community. Please reach out to us if you need anything related to naloxone. We want to support you. We want to be there to make sure that those who need that life-saving drug have access to it. And through our work with the Ohio Department of Mental Health and Addiction Services and the Ohio Department of Health, we were able to announce that distribution of naloxone to communities in Ohio for who were experiencing the highest death rates from unintentional drug overdose deaths. We appreciate our partnership with the boards in those areas to really make sure that we were getting that naloxone to the communities that most need that tool. We were able to serve around 60,000 doses, and that covers 23 primary counties. Those 23 counties represent 80% of all of the overdoses in Ohio. So we really wanted to make sure that we supported the work that you all do. And if you can go to the next slide, I believe it talks a little bit. You can see a couple of pictures. I'm sorry, I didn't notice the slide hadn't changed. But just that, you guys are all doing work. We still support all of the statewide efforts, and you can go to the RecoveryOhio website to find more information about those efforts, or the Department of Health or OMAS websites, and get some access to that tool. We wanted to make sure that we make sure we're supporting that effort, particularly this month and in June. The next slide really talks about how we continue to search for new and innovative ways to fill the gap for Ohioans seeking and finding the correct treatment for their behavioral health needs. RecoveryOhio recently partnered with the Addiction Policy Forum to release the Encompass training. I know many of you may be familiar with mental health first aid. This is a training focused on addiction. I call it the mental health first aid of addiction. And it really spends some time talking about how to navigate addiction, and is a resource for family members who are trying to navigate the complex world of addiction and help their loved ones achieve recovery. The training includes basic definitions, as well as in-depth information about substance use disorders, treatment options, communication strategies, because those conversations with family can be hard, as well as some self-care tips as they work to support those loved ones. The training was developed with an expert review panel composed of prominent researchers and physicians from the addiction field, as well as guidance from the Family Support Advisory Committee that was developed across the country. It's a really wide, nationwide, hands-on approach to developing this tool. I think it's going to bring a lot of clarity and information to families who are struggling to support their loved ones. I think, I wanted to just provide those 2 examples of the state's work as we continue to partner with all of you. Because of you, Ohio has put into action one of the nation's most comprehensive and aggressive strategies and systems to fight the addiction epidemic. And we are preventing overdoses, despite the increase in every life is a heartbreak, but we were lower than the national average increase, and we know that it was because of the hard work of all of you, and we will continue to do that because we continue to find new ways to collaborate and enhance supports for those with mental illness and substance use disorders to make sure they have a home, meaningful work, and communities with less stigma for the disease. With you, we're working to build more equitable systems that allow all Ohioans an opportunity to thrive, and we're making that difference that I think we all hope to see in our communities. Everyone here, as I mentioned, is playing a critical part in making Ohio a healthier place to live for those in recovery, and that is something that you all should be proud of. I'll just say that. We know this isn't easy work. We know this is challenging. And I want to make sure, as the governor mentioned in his video at the end, that you remember self-care as a part of this. I know I've had to. It's been tough. These days are long. The challenges are great. But when we work together and remember that self-care, we can make sure that we're the best we can be for the others and the people that we serve. So thank you, and make sure that you're charging your battery too. I truly appreciate the opportunity, Cheri, as being a part of the Recovery Ohio Council and the OACBHA team for pulling this together. It's always a good time to bring us all together and just remember why we do the work we do. If you need any support in that work, please reach out to us in the Recovery Ohio team. We'd be happy to help. So thank you all.
Director Nelson, thank you so much. Alisha, it's just so good to have you joining us today. And we really appreciate your ongoing leadership from Recovery Ohio office and all the other things you've taken on with the pandemic, health equity. I mean, you are one busy woman, and we appreciate all your leadership. So thank you so much. It is now my pleasure to introduce our keynote presentation for this morning. I'm really excited about this keynote. Dr. Sherrá Watkins will be presenting on That's About White, Integrating Anti-Racism Within Addiction Treatment. Dr. Sherrá Watkins is a leader in the mental health and substance use field. Her passion is to transform systems that perpetuate decreased access and utilization of counseling services to Black, Indigenous people of color. Dr. Watkins' research focuses on decreasing stigma of mental health and substance use disorders, chronic pain and chronic diseases among African Americans, and the intersection of racism and racial bias with chronic pain and substance use treatment. I had the chance to talk with Dr. Watkins a couple of weeks ago when we were kind of deciding who our keynotes were going to be. And she spoke to us with such enthusiasm and knowledge that I can't tell you how excited. I've been telling people left and right, if you only come to one session, really got to come to this session. It's going to be great. So no pressure, Sherrá, but I'm going to hand her over to you, and I'm really looking forward to hearing from you. So thank you so much for being here today.
Thank you for welcoming me, and such an honor to be here this morning. Give me 1 second as I share my screen. So as we're about to get started, you already have in the agenda what our overview will be and what we will discuss today, which is looking at some of the historical and legal foundations of systemic racism and substance use disorder disparities. We're going to explore the role of systemic racism and other forms of racism too, regarding substance use disorder outcomes and structural and individual levels. And then we're going to discuss recommendations for providing substance use disorder care in a more racially equitable manner. And so as we get started, I want to start us off with this quote. Every time we invalidate someone else's struggle with mental health and even substance use, we reinforce the idea that they should struggle in silence. So as we start talking about a very tough topic, I want to make sure that we understand that the work that we do is not just for us, it's also for our greater good. And so let's set the stage. What is not my goal today? My goal today is not to make you feel bad. It is not to shame you. It's not to blame you, and it's not to attack you. However, I want to make sure you understand that some of you all may feel triggered during and after this workshop. My overall goal today is to create an environment that makes you uncomfortable. Being uncomfortable is actually okay. Allow you to think outside the box and to challenge the box that we have created. And to provide knowledge, tools, and a safe place to discuss this topic right in the middle of racial unrest. So we're going to start off with setting the foundation to the definition of really understanding the difference between anti-racist, being called a racist, non-racist, so that way we're all on the same page. So what does it mean to be anti-racist? The term anti-racist refers to people who are actively seeking not only to raise their consciousness about race and racism, but also to take action when they see racial power inequities in everyday life. Being an anti-racist is much different than just being non-racist. We define the term non-racist, meaning that you can have beliefs against racism, but when it comes to events like the murders of Black men by police, and also the murders of other types of races by police brutality, you can watch things from home unfolding on TV, but not do anything about it. Being an anti-racist means that you are developing a moral code that pairs with a commitment to not being racist, whether verbalized or not, with action to protest and end the racist things that you see in your immediate world and also in our greater community. So it must be said that saying that you aren't a racist isn't enough to start the healing process from racism. It takes action, it takes courage, it takes conversation. And so we're going to begin the discussion going further and setting and talking about what does some of the current data say when it comes to Black people specifically in the US. We know that there are about 13.4% of African Americans that make up the total population. Behind that, the soon to pass it is the Hispanic population. And so we know that these two populations in the US are two of our top ones. However, there's sometimes some biases. There's typically some past myths and biases that state that African Americans typically use more illicit drugs compared to other races. But what we know is that African Americans have similar numbers to the general population. When we look at some of the smaller numbers, we know that 6.9% of African Americans have substance use disorder compared to 7.4% among the total population. So it's right there within the same. Now, as we dig through these numbers, we know that there are certain illicit drugs and where African Americans may use higher compared to others. However, overall, it is about the same. So the myth about one population using more than the other is untrue. So when we look at racial disparities among substance use disorders, we know that the burden of the disease is disproportionate among Black, Latina, and Latino and Indigenous people. And we know specifically with the Indigenous people that we have a higher increased overdose rate, 500% between 1991 and 2015. With this particular Indigenous youth population, we see higher use when it comes to alcoholism. And so we have to be mindful that it's not just a Black situation when it comes to racial disparities. It affects multiple different types of minorities. We also know that from 1999 to 2001, Black people had higher substance-related deaths compared to other racial groups. So we know specifically within the opioid epidemic that though there may be more white counterparts who are using, we did see a significant increase in the number of overdoses when it came to Black people. So we know that we have to begin to look at why are we not necessarily seeing more effort, more publications that talks about the overall use of everyone, but specifically, why are we not talking about African Americans and looking at these increased numbers over the last couple of years? So we know that treatment for substance use disorders is less available for minority populations. In one particular research, it showed that counties with higher percentages of Black and Latin residents was less likely to have outpatient substance use facilities that accepts Medicaid. And that can be a great barrier. So when we're talking about barriers to treatment availability, retention, and outcomes, is their facility available? And do they accept my insurance? Or are there programs to accept me if I don't have insurance? So when we look specifically within the opioid crisis, we know that it's further underscored differences in treatment availability. So despite an increase in opioid-related deaths, growth in buprenorphine treatment has been limited to populations with higher income and a lower percentage of people who are not white. So one study showed that from 2012 to 2015, buprenorphine was prescribed to approximately 12.7 million white patients, compared to only 363,000 of people of other races or ethnicities. So there's a great discrepancy in access and also to treatment. So as we go further, we're going to look at how do these numbers that we saw before, why do they look distinctively different between these different races? What are some of the undercurrents and also some of the foundational causes to racial disparities within substance use disorders and treatment? Now, many of these things that we're going to talk about in the upcoming slides have been a part of our conversation. However, let's talk a little bit about it in regards to this presentation today. So we define it into 4 dimensions of racism. Within the first box, we have what we call systemic racism. And within systemic racism, we also can talk about structural racism. We know that systemic racism is a system-wide racial inequality from the collective policies and practices. And we see this in law enforcement, we see it in education, we see it in healthcare, and also in mass media. Within structural racism, which is a part of systemic racism, we look at institutions across the society, but we also look at the societal factors, which includes the history, the culture, the ideology, and the interactions of how these institutions and the policies have affected the culture and history of these particular minority populations. Often what gets confused is the difference between systemic and systematic racism. Systematic racism says that it's a methodical, typically done methodically and also according to a specific plan that's carried out. So there's specific points, specific deliverables and outcomes that's typically created when we're looking at parts of a society and looking at particular individuals or institutions. Institutional racism occurs within institutions and systems of power. We're looking at these policies and discriminatory practices of institutions, of all the ones we just mentioned in the above slide. And also it looks at routinely producing racial and equitable outcomes for people of color. And also setting advantages for white people. So then we go to the very last type of dimensions of racism. Individual, or sometimes called interpersonal. Racism by the individual, such as one's prejudice, that can show up as microaggression, biases, discriminations, and will typically affect how you interact publicly with this particular racial population. So when we look at systemic racism among substance use disorders, we have to be mindful that systemic racism does not operate in isolation. It works in collaboration with health outcomes. It works in collaboration when it comes to the interaction when it comes to other types of isms, sexism, homophobia, transphobia, anti-immigration biases. Once again, there's an intersection between how all these work together and how it also affects certain populations. So efforts to understand how these forms of discrimination and how they operate together is often referred to as intersectionality, which we've commonly been talking about for the past couple of years. So as we talked about setting the stage of the different 4 dimensions of racism, we're now going to talk specifically about one particular category of systemic racism. Let's talk about the legal roots of racial disparities within substance use disorders, because we cannot talk about how to be anti-racist if we don't talk about how we got here. And so we're going to talk about legal situations, and then we're going to begin to progress, and we're going to talk about some other forms of systemic racism and also systematic racism too. So as we talk about the legal foundation, we set the framework for understanding one of the very first legal developments that occurred was the Harrison Act of 1914. This particular act allowed for opioids to have to be prescribed. And also, in order to be prescribed, they now started to create laws and certain regulations in order to treat it. And so it became legally interpreted from this Harrison Act of 1914 that the addiction was not considered to be a disease, and thus it was not within the purview of physicians. That changed how it was being prescribed, what it was being taken for, and also access to it. This began to change later on as we started to talk about some of the new synthetic opioids that was created later on. But the background of this law also included specific moral panic that was geared towards cocaine use with African Americans and also opioid use of Chinese Americans during this time. So we saw that during this time, we can go back and look at the news media, and we saw multiple stories around 1914 that really geared towards African Americans and cocaine use. So for example, they claimed that white women who used these substances were running off with different races. So it created a phobia, it created a mass scare of the use of this particular drug and also risky behaviors. Also in 1914, the New York Times published an article describing how Black men became murderous after being up under the influence of cocaine. And also specifically looking at Chinese Americans, between 1898 and 1914, there was an article that described how there was association between crime and cocaine among Black men, and similar images when it came to threats to Chinese immigrations in relation to opioid dens and on those types of things. And so we know that starting from this was the very first stage of what we call moral panic, where the media would target certain minority populations in association with drugs and cause for them to be targeted. In 1934, we also had the Marijuana Tax Act that associated cannabis use with Mexican reefer madness. And so this sets the stage of, again, targeting certain types of minority populations. So how did this, in this legal foundation of the Harrison Act in 1914, the Marijuana Tax Act in 1934, how did that transcend to where we are now? Well, it led to one of what we call America's war on drugs. Also, it was called the public enemy number one. So in 1971, we know that Nixon coined the term of America's war on drugs, and Reagan continued the perpetuation of the use of that title. And so we, from this war on drugs, we know that there was a higher increase of money that was being targeted to certain types of systems, typically the criminal legal system, also the creation of the DEA. And so it set the stage for specific targeting and also for money to be targeted to not systems for treatment, but for systems of incarceration. And what's interesting is that John Elkelman, who was a part of the Nixon campaign, said this specifically. It says the anti-war left and Black people were the two enemies. We knew we couldn't make it illegal to be either against the war or Black people, but by getting the public to associate the hippies with marijuana and the Blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. We also saw about the lies of the such term as we moved into the 80s and 90s about the crack babies. One particular doctor came up with the term and coined it, and it began to massively evolve inside of our media. And so these types of actions were intentional and targeted within a particular population. Within this war on drugs, we also saw other campaigns that began to also tone in when it comes to our legal framework. We saw the play of Just Say No. We saw mandatory minimums. We saw increased incarceration of Black and brown bodies within our jail cells and prison populations. We saw the prison pipeline. We also saw how there was mandatory minimums that was not fairly associated with minorities. You know, we're talking about a difference between 1 and 100 when we're comparing crack cocaine to cocaine powder. And so it changed their communities and how these communities began to evolve and what was seen in these households. We know that 1 in 5 currently of incarcerated people who are locked up are Black or Hispanic. So though something that started in the 1970s is still once again being perpetuated now in our current society. We also know that arrests for controlled substances like marijuana, we know that the rates are higher for Black Americans, despite both Black and whites use the same drugs at the same rates. Similarly, drug and immigration offenders combined make up 50% of the total federal prison population. And so when we're talking about being anti-racist, we have to make sure that our work that we're doing is not just with treatment, but we have to go against the very fabric of what created the system. We know that there were misguided laws that once again targeted unequal outcomes to communities of color. We know that people of color experience discrimination at every stage of the criminal legal system, and they're more likely to be stopped, searched, and arrested, convicted, and harshly sentenced with lifelong criminal records. And again, as we talk about in the very next slide, what does this lifelong association with the legal system do for these families and to these communities? And lastly, what we know is that prosecutors typically were twice as likely to pursue mandatory minimums for Black people as compared to white people for the exact same charge. So some of the long-term effects and consequences that we saw is that they created a permanent second-class status for millions of Americans. So the drug war enforcement itself disproportionately fell on, of course, people of color. Currently, we have about 1 in 13 Black people who are of voting age who are denied the right to vote because of laws that disenfranchise people with felony convictions. 1 in 9 Black children has an incarcerated parent compared to 1 in 28 Latino children and 1 in 57 white children. And so we know that family dynamics are changing. And so when we're looking at these changes, we have to look at what did these types of draconian laws do to Black and brown families? What other type of structural factors played a role when it came to creating these systems? And what we know, we're gonna go back a little bit further and come back up to the 1970s. But it started off in 1619 with the American chattel slavery. That slavery system, once again, that was a part of the American fabric of who we are in the as far as in our laws and our history. Once again, showed the use Black Americans as personal property that was sold and bought as commodities. And so then we moved from American chattel slavery to Jim Crowism from 1865 to 1965. And then we had the 13th Amendment that abolished slavery. and also involuntary servitude in 1865, except for punishments as crimes. So we still saw some of those types of behaviors in the legal system. And then it began to shift some more. We saw that sharecropping and convict leasing also began to pop up more and stay was sustainable around 1866. We saw the emergence of the Ku Klux Klan in 1866. And then from 1882 and 1964, we saw the increased bodies of lynching, especially across the South, but also even in northern states too. And then we had the creation of the ghettos and welfare between 1968 and 1975, right in the midst of the war on drugs, right in the midst of the beginning phases of the Black opioid epidemic, where we saw our war heroes coming home. So this is not the first time we've had this epidemic. And then we also began to see the crack epidemic beginning to show up in the 80s and also as beginning to start. And so when we look at these, we know that there have been multiple studies that have showed how all of these, as we saw on this slide, what we now term historical trauma or generational trauma, is affecting Black and brown people from a greater likelihood to start using and have risky behaviors associated with substance use. Why are they using them? What do they use them for? Are they using them also for the chronic racial discrimination that's associated with, once again, living in their skin color? We know that more recent work has suggested that chronic stress associated with racial discrimination may create neurobiological vulnerabilities and substance use disorders. We're starting to see the studies of epigenetics show these links between the genetic changes from historical trauma and how this changes how we effectively make decisions, how we effectively, our bodies house different types of chronic diseases, how we're able to treat it, what drugs should be used. And so these studies have begun to show that the role of historical trauma and even the current trauma has a direct effect with substance use disorders. But we also have to look at the bigger system of what we look at as far as within the substance use treatment systems. Though we talk about the historical fabric of generational traumas, of everything from chattel slavery to the creation of the ghettos, we know that there's also implicit bias that refers to the unconscious mental processes that, once again, is associated with many of our medical providers and providers. The judgment that goes from everything. And so included in this research of what we talk about as far as implicit bias, we recognize the negative feelings, the biases, the myths, the beliefs associated with it. And so clinician bias may help explain why people of color in medication-assisted treatment programs are less likely to be prescribed buprenorphine and are more likely to prescribe methadone, which is often, once again, subject to significant regulatory burdens, including more daily pickups, in contrast to it not being associated with buprenorphine and higher use within white people. So we know that they're less likely to have the medication and treatment centers in their area. When they are having it, they're less likely to be prescribed buprenorphine and more likely to be prescribed methadone. And so we look at these systemic changes and systemic structures within our treatment systems, and we go back and look at how it creates, once again, and plays a part in this conceptual model of historical trauma. We look at the mass trauma experience and how that dealt with segregation and displacement, how that deals with physical and psychological violence that was acute and chronic long-term. It looks at how we looked at the economic destruction of local resources and also legal rights of these people. And then the cultural dispossession, loss of cultural roles, cultural identities, language and religion and beliefs. And so we know that as we go into this framework of how do we begin to target and break apart these different types of systematic and systemic type of structures within our substance use treatment centers, it's a part of this whole fabric and concept. And it affects the whole person and who enters into our treatment centers. So what are some of the long-term effects that we see. Survivor guilt, depression, PTSD, other types of fixations to trauma, low self-esteem, anger, aggression, self-destructive behaviors, which is inclusive of substance use disorders, hypervigilance, intense fear, poor affect, and internalization. So as we shift, let's talk about how do we begin to make these changes. And we're going to talk about these changes based off of both micro and macro different types of possibilities. So starting off with our foundation, we have to make sure that we're creating systems of change for anti-racism within our treatment centers and also within the treatment of substance use disorders of people based off the social determinants of health. What are the multiple factors? Everything from education, access, quality, healthcare, neighborhoods that they're coming from, transportation access, social and community context, and economic sustainability. How does that play a part in how we create programs, how we maintain programs, evaluate programs, and create, once again, programs that target particular people of color? So with looking at the social determinants of health as using it as a foundation, or at least a framework, helps us to understand that, once again, we can begin to target the whole person and understand every type of social factor or health factor that may contribute to that person's use and their success into recovery. As we begin to make the shift of using the social determinants of health, we also have to first take an understanding the difference between cultural humility and then being culturally competent. Cultural humility says that it's not enough to think about one's own values, beliefs, and social position within the context of the present moment. It is in order to practice the true cultural humility, a person must also be aware and sensitive of historic realities and legacies such as violence and oppression against certain groups of people. So when we're talking, for example, with a past client of mine, and we talked about their substance use with crack cocaine, and we talked about the generational trauma of watching their mother and father be a part of the crack epidemic. We watched them, once again, multiple legacies being a part of these epidemics and not necessarily been able to receive help, and how that played a part in also how their childhood looked, how they once determined when to access help when they began to use drugs and alcohol. And also, again, when they showed up into these spaces of treatment centers, how their narrative story of how they got here and how they began to use was sometimes diminished based off of not understanding the historical context and realities that created the person. Cultural competent treatment says that we have taken into account that African Americans unique and also other minorities unique backgrounds and struggles. And again, across cultures, addiction is characterized by increased tolerance and loss of control and continued use of the drugs despite adverse consequences. How does each person's culture look at substance use? How does each person's culture look at treatment? And again, addiction is best treated when the context in which it develops is taken into consideration, as you heard me to mention. So in order to be culturally competent, it starts off with being educated. So what are you reading? What are you committing yourself to learn on top of coming to presentations like this to understand the historical representations of the multiple types of minority populations that enter into our doors? And please be mindful that as we talk about specific treatment methodology coming forward, that we don't use a cookie cutter approach. Of course, we're going to talk about the difference between abstinence only and harm reduction. I think I would be remiss if I didn't, but we have to understand that within minority populations, we have to look at the whole person, and no cookie cutter approach will work. Not everyone's going to be completely abstinence only, and not everyone will be completely harm reduction. Some may use a mix. Some may use other different types. And so we have to be open when we're working with minority populations to create an approach that works specifically for them. So as we ground ourselves in specific changes that you can do, starting from very much an individualistic and organizational setting the stage. What are some things to be mindful of being anti-racist and when working with minority populations? When patients walk through your doors, what do they see? What type of decor do they see on the walls? How were they greeted when they entered into your doors? What type of furniture was used? Because there are oftentimes clients would sit and would talk to each other and say that if I go to this particular center, even though there are multiple sites, they have better furniture, they have better food, they have better snacks versus sometimes these that's located in a different area. So clients do talk and they share, they also know the difference when it comes to where the money's been spent and with certain types of treatment centers in certain areas and where it's not. Does the artwork demonstrate, once again, the type of populations that you're serving? Is it eclectic? Does it represent multiple ethnicities and cultures? And then also, when you greeted them, did you pronounce their name correctly? What is often a biggie for a lot of clients who share with me, and also even me specifically, of having an ethnic name, is their name being mispronounced. And one of the most common, easiest thing that you can do when you're mispronouncing a name is a couple of suggestions. Number one, if their last name happens to be easier to communicate over their first name, announce the last name, and then ask them, how do you pronounce your first name? So that way it's a learning curve and you're showing that you don't want to sit there and just guess. When we don't necessarily acknowledge the mispronunciation of someone's name, ethnic name, we also diminish their story. Many different cultures, a name has a purpose, a name has a story, and it has context. So when we say, hey, I called you this name and the person corrects you and you say, oh, okay, thank you. But there's no apology. That sets the foundation. And we know that that very first encounter, what they see in that very first session can determine if the person comes back. We can look at the research and it shows that 50% is a 50-50 chance if they come back or not. Did you make eye contact? And then how long was the wait? And then looking at the intake. What type of tools, screenings, and assessments are you using? Are you asking questions that is inclusive of being culturally competent? So, and asking, was your mom and dad at home? Asking them, who was raised in the home with you? And what was that experience like? Or what was it like to grow up in your family, and how has this affected your view of family and relationships? How did your family look at, recovery, depression, addiction, substance use? Tell me about your traditions and your culture. Tell me about how your family is participating in your recovery process. So using more inclusive and open language instead of, once again, being very much targeted to asking sometimes questions that we believe is based off that population. Or you must have been raised with grandparents or in a one-parent home, or who in your home was incarcerated. While those types of variables may be true, we need to have cultural sensitivity in the questions that we ask at the intake. So once we're doing this intake, we have to take in consideration the rapport. We have to sometimes acknowledge some of the most obvious is that as we're working on this intake, as we're working through this session, we are different races. Do you have any type of questions or concerns based off us being different races? How can we build trust together in this therapeutic relationship? So making sure that the client also has a voice in the treatment plan and what's being discussed, and it's a shared therapeutic relationship. And being open to multiple pathways to recovery and not necessarily putting them into that cookie cutter type of approach. Focusing on their strengths and what they do well, what they've been able to endure and overcome, looking at their resiliency and using that as a part of the treatment plan. Once again, asking them questions about their hobbies and their leisure times and self-care. And then once again, asking about positive and negative moments from their life history. And then what have you learned based off what you have gone through? So when we focus on strengths, we're able to look at understanding the whole person and not just necessarily their story based off of substance use or addiction. And then overall cultural assessment for diagnosis and care. What cultural considerations specifically influence the diagnosis and care? What are you diagnosing the client with? Are we automatically saying that they only have a substance use disorder? Are we automatically saying they also have, any type of depression, anxiety, bipolar, schizoaffective disorder, schizophrenia? Again, really digging deep to understand that person to see, were there symptoms before they started use? Is there a family history of mental health disorders or substance use disorders? And then once again, diagnosing based off of that person, and even getting sometimes supervision or a second opinion or higher level opinion when it comes to diagnosis. Meaning and perceived severity of symptoms in relation to groups or norms. So understanding that sometimes minorities who are very narrative people may describe something as, I just didn't feel like getting out the bed, or I don't know if I want to be here anymore. Doesn't necessarily mean that I have suicidal ideation. It may mean that I'm depressed. It may mean that I don't feel fulfilled. It may mean that I also don't understand, why I'm here, what's my purpose? And it may not be a diagnosis. And so what we know is we're looking at the cultural assessment and how we do the diagnosis and the treatment of minority people. We also take in consideration the role of religion and the role of community within that provides them with emotional and instrumental and informational support. They build networks within their community. And we also can understand how sometimes self-medication for underlying depression, which may be biologically based, and require some antidepressant medications, which can sometimes directly relate to their substance use. So we just want to be culturally sensitive in their diagnosis and their treatment. So some common mistakes as clinicians. Being mindful that we sometimes hear this term all the time. I'm colorblind. I believe everyone's the exact same. So when you take that colorblind approach, you fail to see color and you invalidate that person's experiences. And you also ignore a very important part of their identity, which is their race. You don't see an entire culture through the same lens. I do not speak for all African Americans. I'm just one particular one. And so we cannot ask our clients to be the spokesperson for their population and for their race. But we also can't do the vice versa. We can't look at all Black people, all Hispanic people, all Indigenous people as the same. The burden of teaching should never be placed on the client. We are in that therapeutic relationship where we can learn. However, the onus is on us as the clinician. If there's a particular part of a race or a culture that you don't understand, you can ask for that person's experience with it. And then you and I can go and do our own homework. What should we be reading? What should we be reaching out maybe to other types of colleagues to get some different types of references? And then gaslighting is the act of questioning and dismissing a client's experiences. Acknowledge the racial difference, as you heard me mention before. And then also being mindful with the use of CBT when it comes to race-based stressors and trauma. We often use cognitive restructuring and reframing with CBT, which can diminish and also invalidate that person's experience. We don't want anyone to reframe or once again to restructure an experience based off of race-based trauma. It happened. That's that person's experience. That's what they went through. That's what they believe they saw and heard. And so we don't need to restructure it. So what are other types of more appropriate theoretical frameworks that we can use when we're working with race-based stressors and race-based trauma? And again, in a consensus, when we're treating the whole person, taking in account with religion and spirituality, and there's a difference, of course, as we all know, between the two, taking into account what type of family support that that person may have. Looking at employment assistance programs, again, making sure that they can be connected because unemployment can be a very much a significant stressor for them. Medical treatment, which is a biggie. Many of them may have been using for a significant amount of time, and may not have been up under medical care. So getting them linked to primary care provider so they can be assessed for chronic diseases, STIs, and other types of health conditions is also going to be important. And also housing assistance. So when we're treating the whole person, we're truly creating a very comprehensive treatment plan, as we talk about in our in substance use treatment. So as we make this shift, we went very much starting from individualized types of ways to be anti-racist, how we create our waiting rooms, how we greet, how we pronounce someone's name, how we do the intake, how we do the assessment, what types of questions do we answer. So now we're going to begin the shift to look at more from an organizational type of structure. But I start off with saying this from the organizational structure perspective. The two most effective beliefs that prevent whites from seeing racism as a system is, number one, that racists are bad people, and two, that racism is a conscious dislike, meaning that I consciously believe that I don't like Black people, and that I consciously believe that, once again, that I am against a specific population of people. And so that's not necessarily, once again, true when it comes to conscious dislike. And so we have to take those into consideration when we're talking about beginning to make individual change and how our individual change will go into our organizational change. So some recommendations to consider. We need to address violence, poverty, stigmatization, incarceration, and generational substance use. When we talk about substance use, and then I forgot to mention when we're doing the intake, when we're talking about the different routes of recovery, we have to be considerate that sometimes the person's only home is returning back to a home where everyone or other people may use, or to a community where there may be other people who may use as a part of their system. Using a culturally sensitive approach, again, and understanding a community's relationship to places of worship, housing, employment, and cultural centers that can help facilitate access to evidence-based approaches to treatment. They could always be gateway centers to delivering information and soliciting information. Looking at the economic stability and neighborhood safety can also affect the overall health of residents and contribute to persistent substance use disorders. So again, systemic. Integrating addiction treatment within primary care, case management, infectious disease treatment, OBGYN, behavioral health services, anything that you can think of, integrated care, where we're looking at both mental health and substance use should become a part of the norm. Training in unconscious bias and stereotyping, cultural humility, person-centered care approaches, and again, race-based trauma approaches too, where we're looking at how can an organization begin to prepare their clinicians and frontline staff to begin to treat these different types of populations. And then most important, one of my favorite questions that I ask is, when we're talking about using evidence-based practices and treatments, who determines if it's evidence-based? Typically, a cisgendered white man. Are we taking into consideration that many of our evidence-based practices haven't been grounded in cultural sensitivity, haven't been grounded in looking at generational trauma or historical trauma? And so we want to make sure that we evaluate and determine, can we shift, reframe, integrate, and change some of our different types of practices and treatment programs to be more inclusive. From an organizational perspective, being mindful of what we term to be white institutional values versus transforming values. White institutional values are some of the values that we typically see in our organizations. And as I go through these, I'm only going to hit on maybe one or two for the sake of time, but I wanted to provide a couple of different examples, just because when I mention these, many of us will kind of look to ourselves and like, yep, I've heard that, I've seen that, yeah, I've experienced that too. So one of the very first institutional values is paternalism and power hoarding, where there's a top-down approach of how the information is shared and how decisions are made. And treatment programs is typically designed primarily by cisgendered straight white men or appropriated from communities of color and sold as a commodity. So looking within your own organization, who knows the information? Who has access to the information? Who created the program? Or who's running the program? What would be more of a enhanced transforming value will be inclusive clarity. Decision-making process is inclusive of those affected, of who you're treating. Treatment prioritizes restoration of one's connection to their culture rather than appropriation of other cultures. The second white institutional value that you may see in your organizations is the scarcity mindset, where marketing, outreach, and clinical director decisions reward body brokerage and heads and beds. What are our numbers? Do we have enough people? Are we generating enough revenue? Those types of things that we often hear in our treatment centers. And I know I've heard it and seen it. And again, we do have to generate revenue in order to be sustainable. But we don't have to live a scarcity mindset. The budget should be is typically limited to growth and support of frontline staff. However, from an abundant worldview, which is the exact opposite of scarcity mindset, stewardship and energy and resources leads to program decisions that consider the impact of beyond just financial costs. Decisions about how to allocate time and money and energy is considered the cost and morale, the cost and credibility, and the impact on treatment outcomes. All or nothing, only one right way to recover. Abstinence only programs versus harm reduction, or disease model versus heterogeneous. Again, we see these in our facilities and organizations, but we can transform to a both and type of mentality. Staff should notice when people either use and or language and advocate for more than two alternatives. And we see this in the use of DBT. Program staff using models of treatment and recovery that embrace the complexity of that person's recovery, the complexity of that person. And then another white institutional value that we're in with is defensiveness. Organizational energy focused on trying to prevent the worst harms while protecting its own power. Criticism to the leadership is viewed as threatening and inappropriate or rude. We can transform to having an organization that's based off of curiosity, where the energy is focused on facilitating the best from each person, and also asking for clarity or challenging leadership is viewed as good, is viewed as being supportive, is viewed as, once again, working on changing the structures and the outcomes of our organization. So when we're looking at these values within our organizations, we want to make sure as I conclude the slide, we move from more white institutional values to more transforming values. And as we talk about these values, we look at it from what we call the abstinence from white supremacy mindset versus a harm reduction from white supremacy mindset. And we're going to compare the two models. So typically we'll see it based off this type of language. Our institution is not racist. We won't use problematic banks. We won't take money from problematic funding sources. We will condemn racism on social media. We will hire people of color, and that will be enough. We may even hire a director over DEI, diversity, equity, and inclusion. We once again look at it from very much abstinence only, what we cannot do. However, we know that a better model that we can look at, and using this statement, would be our institution would take actionable steps towards anti-racism. We know this is a process. We will prioritize transforming values and begin to develop intentional relationships with our communities while advocating for systemic change. So when we're looking at leaving this presentation and going back to our organizations, we want to use the harm reduction model towards white supremacy, or the creation of anti-racism model within your organization. And lastly, as we begin to wrap up, I want you to be mindful of what we call the rules of engagement. And I won't go over all of them, but I will hit at least one or two so you can understand what does the rules of engagement when it comes to anti-racism mean. One of the most popular ones that I typically see and have heard from working with different types of organizations and companies, or I've heard from clients is, do not give me the feedback on my racism or my racist behaviors under any circumstances. Or be mindful that if you give me feedback, be mindful of your tone. Be mindful when you give it. Be mindful of where you give it. Be mindful of the emotion that you may have when you deliver that information. And again, in order to give me that information, we got to have some type of trust. We have to have a relationship. And so we understand that sometimes within organizations and within individuals, we can set the stage where if we want to receive feedback on anti-racist behaviors, or sometimes we want to be, in simple words that we say very loosely in our society, if you want to be checked, you have to check me in a way that I can receive it. And we all know as providers and clinicians within behavioral health that it needs to be delivered in a way that should be receptive, but not based off of comfort. So when we write these rules of engagement, how, where, and when you give me feedback is irrelevant. It is the feedback that is needed and that you should want. 2, understanding that it's hard to give, I would take it any way I can get it. From my position of social, cultural, and institutional white power and privilege, I am perfectly safe and I can handle it. If I cannot handle it, it's on me to build my own racial stamina and resilience. So let's rewrite the rules of engagement, how we challenge each other, how we have these courageous conversations, and being mindful that we don't have to do it in the box. We are challenging the box. And then lastly, the last 2 slides looks at specific responsibility of anti-racism allyship, meaning that, are you self-educating yourself? Are you looking at your own emotional literacy? Also, are you looking at, once again, questioning and also reflecting upon what you're experiencing and other people's experiences? What are you reading? Or when are you doing doing a self check-in to initiate, to evaluate, are you progressing? And again, are you remembering where you started and what's the purpose of this education? So again, this particular slide looks at a lifelong, non-linear type of allyship. It doesn't just start because of the social justice movement being ramped up last year. We've always had these issues within minority communities. So it's not going to happen overnight. And it means that we have to always have this continual type of change. And so the slide also, again, supports this one here, the exact same thing, but just in a different way. I want to end by asking, are there any questions? And what's your action plan?
Dr. Watkins, you've gotten so many comments of how refreshing your presentation was and how great. There are a couple of questions that I thought maybe you could answer, and I'll read you the first one, okay?
Okay.
Any suggestions on how one can better advocate for the minority clients and their needs in a program when you are only one of 5 minorities on a treatment team of 21, and at times you try to address racial disparities, and when these disparities are mentioned, they're not thoroughly addressed or considered. So how about that one?
And that's very difficult because oftentimes you don't want to be sometimes considered the token Latin person or token Black or minority person to always bring up minority issues within the workplace. However, it must take leadership involvement in creating any type of structural change. So you can definitely print out this PowerPoint and send it to leadership. And 2, you can also be specific in saying, what is one thing that we can do when working with minority populations? Sometimes the systemic change will take a long-term type of view, but when working with your peers, looking at what is one thing that we can do and work and do that one thing great, and then begin to add upon that. So we know that we have to have a larger action plan, but starting off with one thing. So even if it's saying making more inclusive questions on our intake, are once again looking at how we run groups and how we start group and what type of interventions are we using? Is it inclusive?
Okay, great, thank you. Another question is, Dr. Watkins, if you're doing an intake and bring up the question about race, what if the person says they do not want to work with someone who is white/Black? what would be an appropriate answer to say to them?
I respect your opinion. And I will see within our organization if we can make this happen. We all have to be honest. Sometimes we have the availability and sometimes we don't. And so you want to honor that person's feelings and also honor their honesty. And then you can also ask, you know, if we're not able to provide this for you, what can we do to make sure that you feel safe and also feel as if we can be inclusive in your recovery process? Because again, that's going back to sometimes we don't have the numbers to match our communities, and that's just based off rural populations and geographic locations. So we have to have some honesty with that conversation too.
Okay, great, thanks. Any suggestions as how you get more criminal justice systems to pay attention to the new trends and treatment of minorities?
The legal system part, that's the most difficult piece. We are seeing the changes and within our legal system, but it comes from looking at our representatives who we're voting for. It comes from, once again, making sure that we're challenging our system and asking for them to look at how can we transcend from where we used to be? If we're having these high numbers of minorities in the prison population or jail population, what could we do different? And we are seeing jails and prisons make some effective changes with how they deal with mental health and substance use. So it's going to take more of those type of directors to talk to other directors to make the effective change. So advocacy is going to be key. But I truly believe that the legal piece is going to take a little bit more work and some time before we see a whole bunch of change. We're starting to see the change that came from the mandated minimums being changed, where we're looking at when it comes to drug charges. And so we're starting to see that, but I think it's going to take a little bit more time and some more stronger policies and politicians to do the work.
Okay. Where can folks gain access to the information you had regarding rates of use and SUDs mentioned here?
So I did a PowerPoint for NADAC. I want to say it was earlier this year. And it has the particular data in there, but also I gained it from, I can't think of the name of it off the top of my head, but all the data is listed up there and where I got the data from. If I'm not mistaken, this is don't quote me on it. I want to say it came from SAMHSA's 2018 data that I received.
Okay, great. That's the end of our questions. So Dr. Watkins, let me just thank you so much. This was a great presentation. As I said, there are many, many comments in the chat thanking you for your presentation. So thank you so much. For those of you that might be interested in hearing more from Dr. Watkins, she and her twin sister are presenting at 1 o'clock this afternoon. They're presenting an 1.5-hour session. So you may want to join her there as well. Although we have lots of good sessions, but if you want to follow up with Dr. Watkins, she does have another session.
All right,
So,
thank you.
Thank you. So with that, we're going to wrap up this morning's general session. I want to thank again all of our speakers, Kyle, Alisha Nelson. We appreciate the governor's video, and certainly Dr. Watkins. You all did a great job. Again, I think we had a great general session, so thank you. We've had a great 3 general sessions. We've had good speakers throughout, so we're very pleased with that. This will be our last general session. Next